rehabilitation is probably the most neglected part of the trauma spectrum. Look around here and see where do you send somebody to get better from trauma. And I'll guarantee you can find plenty of places to get better from stroke or a heart attack, but trauma. So that's part of the reason, one of our biggest problems is traumatic brain injury. I've asked Dr. Lee Henderson to talk about that because she is our expert on this field. So Lee.
Thank you, sir. So I'm Lee Henderson. I'm a rehab doc, physiatrist, DNR. I'm here part-time. They needed me to be at a level 1 trauma center so I can say what I want and they can't fire me. Although they might try, but they can't be a level 1 trauma center. So I trained in Birmingham. I'm from South Louisiana. I went to med school here. Actually, I finished in '94. I did my transitional internship here. I got to make it up like I wanted it, and then I went on to Birmingham. My husband's a urologist in town, just to tell you. I have 4 children, and all you ladies going into medicine are there. Think about having a family and what specialty you choose, because I was fortunate that I chose the specialty that's easy to have a family. Anyway, so there's my spiel. So I'm going to talk a little bit about head injury, and I'm going to make an excuse about my slides. They're from an email that I sent to somebody, and they made corrections. I can't find my original slides, so I'm going to have to redo them. So there's a lot of misspellings and stuff, so just forgive me. Anyway, I work for neurology and trauma, so I do a little bit of both. So we'll talk about head injury epidemiology. 1.7 million head injuries annual. So these people are not just somebody that's unconscious for days or whatever in the ICU. These are people that go to the ER and they go home and they've had a positive loss of consciousness, mild, maybe 30 seconds, but that's still a head injury. I had an attending who said, a head injury is a head injury is a head injury. And so anything like that is a head injury, and we can't ignore those because those are the majority that leave. 80% are ER visits. So those people go home. They get depressed or they have like post-concussive syndrome issues later, and they kind of get ignored, or they ignore them, or the kid that, the concussion from football is having trouble in class because he has attention issues or he has headaches or whatever. So those are the majority. So we really have to not ignore that. Bimodal, the younger, there's the older ones, male to female. It's, males are higher risk, they're going to have more head injuries. It's kind of the same, it's a simple thing. Ejections are the most common cause of death from a head injury, and then an MVA is the most common cause of a head injury, period. Violence is second, and alcohol is involved in a bunch. So severe is coma, GCS of 3 to 8, moderate, and 90% are mild, like we talked about. So the ones that we see here are a very small percentage, and that's what I think we miss a lot, at least out in the private community. I've seen it. I think it's getting better because of all what's going on with football and all this stuff, and there's more awareness, but there's just a lot that we do kind of miss. So post-traumatic amnesia is the most common predictor of outcome, and it's when you start being able to lay down that new memory. You get 75% score on the GOAT or whatever 2 days in a row. You know what you had for breakfast. You know what you had for lunch. You know who visited you. That nobody's cueing you to tell you. You can remember it and can go on. And that's when you're out of post-traumatic amnesia. So mechanisms of injury, and this is sort of the primary is contusion, cortical tissues, diffuse axonal injury. What do you call that? The hallmark or whatever is white matter petechial hemorrhages. On a CT scan, if the CT is normal, does that mean they didn't have a head injury? No. So it's so annoying when people say, well, the CT was normal. Really? Who cares? Your CT is not going to be normal. Like an MRI can show diffuse axonal injury, but still, an MRI can be close to normal. But if they're unconscious, something's wrong. So, those are that's like a board question for my groups. So secondary injury, excitotoxicity, your release of neurotransmitters, glutamate, calcium, mitochondrial failure. All of this intracellular stuff. So swelling is increased intravascular blood, and edema is increased brain volume, so brain water. So those are two different. We use swelling and edema interchangeably, but theoretically they're not, or semantically they're not. So we have vasogenic edema, which is, and these are my, don't hate me for my typos. Vasogenic is extracellular edema, cytogenic is intracellular edema. And I have all of these, like I have so much stuff on it because the neurology guys love to have everything. So they can just kind of read the slides and use them to study. So that's why I kind of do that. So focal versus diffuse injury, you have contusions. The most common are frontal and temporal. Epidural, they're lucid, then they're down. So you have the person that kind of's knocked out, then they get hit and they're dazed and they wake up and they can walk into the ER. And I literally had a guy when I was in med school that walked into the ER and said, I got hit in the head by a bat. And as he's walking, he goes like this. And so he's the one that I remember because that was so textbook. Subdurals, you have 30% in severe traumas. Subarachnoid hemorrhages or aneurysms, AVMs, and you can have it from trauma too. DAI, those are the grades, just so we know what grades are, but grade 3 DAI involves the brainstem, and that's not a great one to have. Don't write people off though. Like if you're in the ICU and somebody has a severe brain injury, and Dr. Weigel probably remembers this young lady who had brainstem stroke. It was a car wreck and she had bilateral carotid dissections, and she wasn't as like a head injury like this, and she had brainstem contusions and all this stuff, and they were going to pull the plug on her Friday night at 7 o'clock. The family changed their mind at 5 o'clock. A week and a half later, she mouthed to her husband, I love you. She went to rehab and was singing before she left rehab. So 4 children, and she's with them now, which is, I get goosebumps. Anyway, so don't write people off. Recovery, plasticity is the ability of the brain to repair itself. We can't repair a whole lot, but it can do some. We have neuronal regeneration, and we call that collateral sprouting. Functional reorganization is like unmasking, neuronal reorganization. And like collateral sprouting and unmasking are sort of some like catchwords that we use to help us learn about the brain stuff. Diascasis is spontaneous return of function. It's the function lost in an uninjured part as well, and so it finds a way to get back. We have disorders of consciousness, and these are just some different things. It's a function of the ascending reticular activating system and the cerebral cortex. In your coma, your eyes are closed, but there's no sleep. So closed, but no sleep. In a vegetative state, your eyes are open, but there are sleep-wake cycles. So those are just some things to know, to think about. So coma, no sleep. Persistent vegetative state and permanent vegetative state, those are just things to have. Just want to make sure this isn't a kid. No, okay. Glasgow Coma Scale, I just put it up for you guys. You guys, are y'all in surgery right now?
We're all pediatric residents.
Okay. So this is the Glasgow Coma Scale. I know y'all have dealt with it. We don't need to go over it. So initial management of head injury, and I included this just for like ICU purposes and just because this is what we do. This is not anything that I would be involved in. You are. We get resuscitation. It's all the basics. The ABCs, CT, MRI kind of thing. We'll do serial exams. The GCS is so important in the field because they come in intubated. So what was their GCS before? There are 3T, yes, but what were they really before? Monitoring, a bolt, sedation. Lorazepam does not decrease respiratory drive, so that one's an okay one to use. But in the long run, we don't like benzos, and I'll come to that earlier. And then there's, of course, surgery if we need surgery. Acute management, your CPP, we want it here, ICP monitoring. You use it for a GCS of 3 to 8 with an abnormal CT. And if they're older than 40 or their systolic blood pressure is low. And I looked at, these are parameters that come from my board stuff, and I've talked with some of our ICU people, so I've made some changes. So it's not ideal, let's say. Like we might have some different things. You might have a different way that you guys look at it, but this is from my stuff. Head of bed less than 30 is when your ICP is your intracranial pressure is going to be higher. So you want it up. Make sure the C collar is not too tight. Head is midline. We do hyperventilation. We use mannitol, things like that. These are just sort of like for like completeness sakes. So management in general, we want stabilization, preventative stuff, bowel bladder, nutrition, there's spasticity, swallowing, all of these things are kind of normal. We have 5 senses, and we want to avoid overstimulation. I don't know how many times you guys have had patients that have a head injury and their parents or their families in there going, "Daddy, you fell and you hit your head," and they're screaming at him. And he doesn't know what's going on, but he's getting all like this, and all this noise. Like our ICU right now, they're going to redo it so we can have separate rooms for each patient, because that's so important. Day, night kind of things, and the noise. And we forget, as physicians and caregivers, nurses, everything, we forget that this patient's like sick. And we're yelling and having a party, chatting with our friends, and we forget that that kind of stuff can irritate them even if they're unconscious. So once they're emerging out of coma, we use neurostimulants for arousal. Some of the studies, and Dr. Samra's not here, but was talking about amantadine, which you'll hear later, that you have to use it within 48 hours, but really not necessarily. Once they're emerging, then you can give them something to help them out. We've done there have been studies on amantadine, 4 and 5 weeks out. But serial GCSs are so important. Use yours, but your nurses too are so important, because they're going to get a little bit different response. And so a patient might do something for you, but not for her, or do something for her and not for you. So it helps us to know where they really are. So physical issues, there are swallowing issues in up to 85% of patients with head injury. So, oh my goodness, let's not ignore that. Let's not say, oh, well, they seem to be okay, but silent aspiration is so common. And a speech therapist that might hear would say, oh yes, please. There's so much silent aspiration. So a good cough in 77% of patients that have swallowing issues. So we're missing a lot, and we need to just pay attention. They have slower gastric emptying, they have incontinence or retention, constipation, obviously, multiple trauma. Look at all the other issues. They have fractures, this and that. I mean, those all play a huge part in everything that's going on with this head injury. Long-acting pain medicines are better in a way, but sometimes we like to use shorter acting just so we can assess their arousal. So it's patient specific and situation specific. Everybody's going to have a different opinion. So rehab. Now we get to where this is my thing. We have a lot of agitation, up to 50% in severe TBIs. And we want to stop agitation because it's annoying to the nurses. It can harm the patient, whatever. But sometimes do we really keep them down more than we really need to? Obviously, if they have an NG tube and they have all these IVs, we can't let them be pulling it all out. But those that don't, we put in posy beds, those little veil beds. So it's a twofold there. You want to minimize the agitation so they don't harm themselves, but you don't want to snow them so you can't tell what's going on. Environment can really help, like I was talking about, a small, like a closed room, quiet, sleep-wake cycles are normal with day, night. Even if they're unconscious, put the light on. Their body will sense it. And restlessness, we use, these are some meds that we use for restlessness. Trazodone, it's a great med. Tegretol, Depakote, aggression, metoprolol, Depakote, and patients with a psychiatric history, risperidone is a good one. My mouth is so dry, so please forgive me. The Rancho Scale, it's actually been updated, and there's like 9 and 10. But I try to, Rancho Scale is very important in rehab, and so when you're referring a kid to rehab, they're going to want to know their Rancho Scale. And so I'll put it in colors because, like, the first 3 are no, generalized, localized. Then you have confused, 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 and you have appropriate, appropriate, appropriate. And so that way you can kind of think about it. But I still use my little plastic card that talks about it. And there are like 9 and 10 are purposeful and appropriate standby assist, or purposeful and appropriate independent. I mean, it's really kind of stupid, but I hadn't been able to make corrections. So complications, post-traumatic seizures, sir.
At what point can we send people to rehab? Because they'll tell us that if they can't cooperate, then they can't go to rehab.
Well, they have to be able, so from that standpoint, what we look at for inpatient rehab is they have to be able to tolerate 3 hours of therapy a day. And that's not a difficult thing. A patient with a head injury is different than a patient who has like a hip replacement or a knee replacement or even a multiple trauma. are they too debilitated to tolerate 3 hours a day? These head injuries, can they tolerate it? Yeah, they probably can. And we break it up too. And speech therapy is a big part of a head injury rehab. So it's when they can participate, follow commands well enough to be able to progress. In rehab, we are expected to make, and I think I have this later, but I'm going to go ahead. The FIM gain is a functional independence measure. And we're going from that now to something else. But the scale goes from like a 0 to a 7. And a 7 is completely independent. You don't even have to touch the wall to do anything. And like a 4 is 25%. A 5 is standby assist, where you just have to kind of stand there to make sure they're safe. A 6 is using a walker or an assistive device kind of thing, or you have to push up. That would be a 6. So we are expected nationally to make 2 FIM gains on a patient. And so if we had a head injury that is like laying in the bed, following commands intermittently, and they're like non-weight bearing, and they can't even no to non-weight bear, that's where we don't see that we're going to make some gains enough. We have to wait till they're more awake and they can make the gains. A long time ago, when I trained, we had people in a coma, and we keep them there for 6 months, working on them, waking them up, doing range of motion. But that's unfortunately, LTAC is here now, and so that's where they go, and then they come to rehab. So it's patient dependent on different things, like a head injury that is physically doesn't have anything else going on. They have no fractures or whatever, and their weight bearing status is full. It's a lot easier to take somebody who's not there, that they can at least, we allow them to get up and walk and do things with supervision, rather than the guy who has non-weight bearing to 2 limbs, which I think we have one now. We can't take him because he doesn't know. You know what I'm talking about. He doesn't know enough that there's no safety there. He's not going to progress. We have to wait till these are better so that he can progress. And it's unfortunate. It's a messed up system. So did I answer your question? Sort of? Okay. So post-traumatic seizures, post-traumatic epilepsy, most are simple partial, usually in the first few months. 5% of head injuries have late seizures, but only a few of them have one or in the first week. Risk factors, obviously the worse head injury, the worse it's going to be. The more at risk, the more likely they're going to have seizures. You do an EEG exam, and so the neurologist, an increased prolactin confirms a seizure, but a normal prolactin doesn't say there wasn't one. Although Dr. Romero said, well, what's your baseline prolactin? Well, I don't know. So this is just, I'll put that in because it's an interesting kind of board thingy, but it really, what is the baseline? So we don't really even use it. So we do prophylaxis for 1 week only. Studies have shown that doing it for longer doesn't change anything. It doesn't decrease the risk of seizures. So it's, we do Keppra for a week. A lot of times, however, the patient gets sent out on Keppra forever, and I'll say, well, why are they still on their Keppra? Have they had a seizure? Oh no, we just kept them on it. Well, so when you're writing an order, they've not had a seizure and you're doing for prophylaxis, put for 7 days. It's just like antibiotics. Aren't you supposed to put for how many days you're going to treat them? Because what happens, I'll get patients that have antibiotics for 30 days and it was only supposed to be for 7. So that's a whole aside. Anyway, so carbamazepine for partial, valproic acid for generalized. We do use Keppra as well. Phenobarb and phenytoin cause cognitive issues and slowing, so don't use those at all. I have a list later of all of the ones, all of the meds not to use in a head injury. But you can stop it once they're seizure-free after 2 years, get an EEG, and so many patients still are on it 15 years later. They hadn't had a seizure in 12 and a half years, and they're still on their Tegretol. And why? So autonomic instability, dystonia. We've got a patient in the ICU right now who's like in storm, and they're using bromocriptine on her to help, which is not on my list, and I need to put it. Within the first 2 weeks of a head injury, you have hypertension, tachycardia, hyperthermia. So the fever is not necessarily infection. It can be this. Perspiration. It's increased catecholamines. They're storming. They're in like the fight and flight. You treat it. Lipophilic beta blockers, propranolol is the best one that crosses the blood-brain barrier. Dantrium, which is a great muscle relaxer as well, but we use it for that. NSAIDs, Tylenol, cooling blankets, all of this stuff. And dopamine agonists, amantadine. It's one of my favorite medicines in the whole world. You'll see it about 15 times later in the slides. Posttraumatic hydrocephalus. So ventriculomegaly is very common, but posttraumatic hydrocephalus is rare. So look at like 40 to 70 and 4 to 7. I mean, it's like amazing how rare it is. But I had a lady here that, not here, but in practice, I'll tell you about it anyway. Anyway, incontinence. The textbooks will tell you bladder incontinence, and it is. Ataxia, gait disturbance. Their balance is off, but it's like their feet are frozen. It's almost Parkinsonian, but it's like they cannot, like they're stuck in the mud to transfer. You have to move their legs. They can't do it. Declining cognitive function or dementia. Now, so the acute post-traumatic hydrocephalus patient, the one who's had a head injury or whatever, they're going to have declining cognition. But the others, like some patients have some mild dementia. They come in for dementia workups, and they're found to have hydrocephalus, like normal pressure hydrocephalus, and it's not just dementia, it's that. And so we can't go like diagnosing everybody with normal pressure hydrocephalus, but then you can't miss it either. And you treat it with a shunt and dial that down gradually. And we had a lady who was 85 years old, fell, hit her head here, had some subdurals. Like she went to rehab. This is like February. I see her in June, and she was better. She was min-assist. She still couldn't say hot pink after I said, what color are your shoes, hot pink kind of thing. Her memory was still that poor. So she fell in the nursing home, and they did a scan June 18th at Menden, and it was normal. No hydrocephalus, I see her July 13th or July 7th or something like that, and she was playing with her gait belt, just like this. Totally not the same person. She had declined over the past 3 weeks, the family, to where the point that she wasn't moving. And I said, Ms. Sybil, are you peeing on yourself? And they said, oh yeah, she's having incontinence. She had a bowel movement as we were talking and had no idea. So I actually 911'd her from my office because her family couldn't even move her. They barely could get her in the car. And she came here, they tapped her, and she woke up. And she got a shunt, and she did great. And a few days later, she was kind of funky still in rehab. I called Dr. Willis, the chairman of neurosurgery. I said, Dr. Willis, can I get somebody to come and dial her shunt down? Because I think that we need just a little extra. And he said, I don't have anybody. So I came and got the thing, got the residents to show me how to do it. And she and her granddaughter and I did it in rehab, which is sort of crazy. And 45 minutes later, she's reading off the TV. So-and-so's gotten convicted, da-da-da-da. She is jamming now. She is weak still, but it was just amazing. Like, when did the hydrocephalus really start? Should she have gotten better? Was she already having some mild hydrocephalus for months that we kind of missed? I don't know. That's a whole nother aside. But those patients that you see that have a diagnosis, you remember them, you're not going to forget, and you're not going to miss it that next time. You might overthink something, but you won't miss it. So cranial nerve injuries are important. Olfactory, 25% in head injuries. So those kids that don't want to eat, or those people that are not eating, their appetite's poor, maybe they can't taste anything. It comes back within 3 months usually, but that could be it. I mean, it's not like it's, well, what's wrong? Why aren't they eating? Da-da-da-da. They can't smell. You can't taste. I wish that sometimes that would happen to me. Facial injuries. In fact, there was a guy, facial nerve injuries, taste, facial expression, kind of thing. Vestibular issues, my gosh, it's so common in head injuries. Optic injuries, you can have so much. And just like a stroke, you can have stroke symptoms with a head injury. I have one guy who's got a fifth cranial nerve palsy here, just numbness on the side of his face. And he's got some slits, like in his visual field. He's got some, visual field deficits. His MRI is totally normal, but something happened, obviously, because he's got this, and he's not, faking it. He was the guy who got his chest crushed by the jack. Remember the jack that fell on him? The car jack failed. And so he had respiratory stuff, obviously, because he had a crushed chest, but he ended up with these other things that we're dealing with, trying to figure it out. Ocular motor issues, those are kind of simple. Visual dysfunction, there's just so much that can happen that we don't think of because they can't tell us, oh, I can't see on this half side. You know, but you can pick it up. And your therapist, like your OTs and your PTs and your speech therapist too, the speech therapist says they do not attend to the left side. So they have a homonymous hemianopsia. And they'll leave that side of their plate. Like literally, like it's like half eaten. And that's our clue. So if they can't tell us, we can figure it out. Focal issues are a visual process. Conscious vision is occipital cortex. Ambient is preconscious. So ambient vision is different. Neuroophthalmologists are great to help. Dr. Vukovius comes over here. He's awesome. He's got a partner now. And they do visual rehab and prisms, working on different things. I have one patient who's got a lot of dizziness. She's about to do some rehab with Amy Coburn in town on the computer to help with her visual disturbance and her dizziness. She has like a 1% degree off. And that little bit is messing her up. And so they do prisms and change their glasses and to get them to where their vision is better so they can walk. Because it might not be that they have balance issues. It might be they can't see and so they're walking like this. So rehab is a team. Just like medicine is a team, but rehab is really like, it's not just the acute, let's get them sick and go home or go wherever. Rehab is from here to their life. I see patients from here and I follow them forever, as long as they need. And so it's not just me, it's everybody else that's working with them, and the therapists are a great part, or the bigger part. So agitation, and we talked about this earlier, is a subtype of delirium. It is during post-traumatic amnesia. They don't know they're agitated. You can't tell them, stop it. They don't know, they're just trying to move because they don't realize what's going on. They're emotional. It's usually in the first few weeks. It's really not that long. Most common in frontotemporal. And there's an agitation behavior scale that we use, and we don't really use it. We should, and so we're working toward that kind of thing. But reduce stimulation, protect them from harm. Like I said, day, night, keep it quiet. The TV doesn't need to be on. They're not watching the news. They don't care. They don't really need the TV on. Because any noise can aggravate them. They're going to sleep and wake. But it's good to get some sort of, light, dark kind of thing going on for them. And tolerate it. That's really important. They can't help it. So pharmacologic management, not Haldol. Haldol is the biggest no-no in rehab. We love it here. We use it, and we're using it less. But it's not us. It's everywhere. But it slows recovery and prolongs post-traumatic amnesia. Geodon is a faster onset. It's great. We use it a lot. It helps. Seroquel is sedating. It helps at night. And in the pediatric population, I can't even begin to know what you guys should be using or not. So if y'all want to say something, tell me. I don't care.
We use a lot of Geodon.
Okay. Now, I get them mixed up. Keith Scott. Keith White I've known for years, so Keith Scott, it's hard for me to say his name. He said that there was a study that Geodon there were no recorded deaths in Geodon from QT prolongation as opposed to Seroquel and Haldol, which that was interesting to me. I still would never use Haldol, and I'm not like the biggest fan of Seroquel. Geodon, I really like Seroquel better just because I like to use it just at night. But Geodon really does work really well, and you can stop it and you can titrate it up, and it will help and at least keep them from hurting themselves. Benzos are detrimental for cognition, can prolong PTA, but used sparingly for acute agitation is okay. Like Ativan is okay. I don't mind it. We don't use Xanax, so Xanax just shouldn't be around, except for me before this talk, but I didn't take any. I've never had one, but it's just, we don't like benzos for prolonged stuff because it's detrimental benzos aren't a great medicine anyway. But if we use it, lorazepam, midazolam, they have a short duration of action, so you can assess their cognitive function soon after they calm down. Lipophilic beta blockers, propranolol is the best one, metoprolol is the next best one. So those are great for agitation if their heart rate can tolerate it. And you can go up to 500 milligrams a day. You can use it so much, and it's something that we don't use a whole lot, but wow, that's a whole lot better than putting them on Geodon, if that'll work. And Depakote, Tegretol also work for agitation. We use those a lot as well, but they stay in the system so long and they can cause so much sedation. I don't like them as much unless we know where the patient is before we do it. Antidepressants are great for agitation too. Buspar, and I'll say this later, Buspar is like such a low side effect profile. It's a great medicine for anxiety and agitation. Anoxic brain injury, there's a lot of decreased serotonin and norepinephrine. So in anoxics, I love to use Zoloft. And I love Zoloft anyway, because it's the most dopaminergic of all the SSRIs. Use neurostimulants, amantadine, love it. Ritalin wakes them up. I've not used Adderall a whole lot. I use it later once they're awake and they need attention issues. But in the early parts, I don't. Like the little lady, that 85-year-old lady who her attention was terrible even after her shunt. I put her on Ritalin for a bit. She did great. And, we weaned her off of it once she was better, and she's doing great now still. We use lithium for the manic cyclic mood issues. And Depo-Provera this is one of these I put in for hypersexuality. Of course, you're not going to use it acutely, but it's one of those that's kind of like a board question or something. Heterotopic ossification. I don't know how common it is in the pediatric population with head injury, honestly, but it's where bone doesn't need to be. Bone shouldn't have bone there. Usually it's in the first few months. It's in an affected area. I had a spinal cord guy who got HO in his hip. They treated him with Indocin and one of the bisphosphonates, and it went away, and it doesn't bother him anymore. It's amazing. But I've seen it so severe that they just cannot move, and they're swollen limbs, and you think it's a septic joint or it's infected, but it's HO. A bone scan is the fastest way to check it out. It's most common hips, elbows, shoulders, and knees. Obviously, the worse of the head injury, the more at risk they are for HO. So other complications, hypertension usually resolves. Clot, they're clinically silent. How many do we really miss? After, what do we do here? 2 days in the ICU we start Lovenox.
Depends on what the injury is.
But if they have a little bit of a bleed, like if they're neurosurgical, like if they had surgery, they like to wait 48 to 72 hours.
Neurosurgery, like support 72 hours.
Yeah.
The literature doesn't really support that.
And so there's talks going on about all that. But, so a quick aside, T10 fracture, fell from the deer stand, totally intact, everything, but he had surgery. And on the 18th, he was transferred to us from rehab, and he wasn't on heparin. He wasn't on Lovenox. So I looked back, I said, he never got any, they must have not wanted it. So I didn't put him on it. And I'm telling you, I screwed up. So I didn't put him on it because he was up walking. He had a TLSO, but he was up walking, strong legs, not swollen, nothing. 5 or 8 days later, he's back here with a PE to his left lower and middle lobe. Retrospectively, 2 days after his surgery or a day after his surgery, he had to go to step down from the floor because he had some shortness of breath. And I said, you know what? I wonder if that was the first one. And then he had the big one that came. So, those things happen, and thank God he's fine. But it's one of those things we miss. Neurogenic bladder, they have small voids, normal post-void residual. So they're peeing a lot. We use time voiding. Sometimes we use ditropan, Detrol. Those can cause some cognitive side effects. Merbetric does not, but it's usually non-formulary and it's expensive. But then you can also have retention with those. And so you have to kind of play it and figure it out. Spasticity, we use baclofen, dantrium, tizanidine. Those are the most common ones in head injuries. Valium we use in spinal cord injuries a lot, but because it's a benzo, we don't really use it in head injury. Baclofen and tizanidine are central acting. Dantrium is locally acting at the sarcoplasmic reticulum, which might be some sort of good information to have. Yes, it can cause sedation as well, but it's locally acting, which a lot of people don't know. And we use it also for, can't think of the word, malignant hyperthermia. Yeah, in the ICU. So that's the most common use of it, but it's a great muscle relaxer. I use it a lot in private practice. It's I kind of fell back in love with it, and it's awesome. Other complications, think of the neuroendocrine system. We check them a month later, 3 months later, a year later to make sure everything's good, because that can happen and we might miss it. Anterior pituitary stuff, growth hormone, which I didn't know. That's like the most common one after a head injury. So it's something we need to check. Hyponatremia, you know, these are all your ICU stuff. SIADH, you treat with fluid restriction. Salt wasting, you treat with fluid replacement. And diabetes insipidus, DDAVP. But there's all of these. I'm not going to go into all of the different sodiums, this and that, because I don't even remember it right now. Nutrition is huge, huge, huge. Within 48 hours, we need to be giving them some nutrition. By day 7, they should have full caloric replacement. And they need 100+% of their basal metabolic rate. A lot of it needs to be protein. So these are our goals. Enteral feeding is important. Why? Because it's better than TPN, obviously, because of their gut. And gastrostomy is better because of the decreased risk of aspiration, which is a huge risk as well. NG tubes, sinusitis, and a rehab won't take an NG tube. There's not one rehab that will. Now, an LTAC will, but acute inpatient rehab won't take an NG tube. If they need an NG tube for a long time, they should have had a PEG. They should have had a PEG. They should have had a PEG. A PEG, yes, there's a risk, and families like, I don't want that hole in their stomach. Oh my gosh, put the dang thing in, we'll pull it out, but they need it. And so it's something that we sort of hesitate sometimes, but we really need to just do it. I had a patient that had a stroke, and her daughter, I said, you know, she is not going to be able to eat enough. After a week with the PEG, she was eating fine, which, you know, it's like, oh, but the daughter said, you know what? If she hadn't had it, she said she wouldn't have gotten better this fast. So, you know, it's like, you never know. And then some who refuse the PEG end up fine. They never have an aspiration pneumonia. And we're still, like, I discharged somebody because she refused to have a PEG. Because my staff said, I cannot take this risk. And her mother died after her PEG, and that's why the patient didn't, and she's jamming. She's fine. So you can't, not everything's perfect. So for cognition, you have arousal and attention. Ritalin is noradrenergic. Amantadine is dopaminergic. Memory, there's not much evidence-based thing to help with memory except for time and repetition. But Ritalin and diazepam have been shown to help a little bit, so we use it sometimes. Depression, anxiety, I said Zoloft is the most dopaminergic. We use Effexor a lot. Buspar, low side effects. Remeron is great because it also helps with insomnia and appetite. And so those older patients that are having trouble with sleep, you get a threefer. And less medicine is better. And so if you can find a medicine that will treat a few things, then it's better than, you know, treating a medicine and 3 different meds. And so Wellbutrin lowers the seizure threshold, so we don't use it. Therapies obviously are the most important. And it's really funny that, you know, you think of rehab, and I'm talking about all this, and I'm going to have one slide on therapies because there's so much that they do. But basically, you know, PT, look at all this stuff. I mean, they're not just walking the patient. Now here they might say, yeah, they're walking 300 feet, and so they can go home. Well, no, because they're hitting the wall, or they're kind of doing this, but they can walk 300 feet with a walker. I don't care. They don't know that they walk 300 feet. But spasticity, you think of all the physical, all the fractures and everything. PTs really do work really hard figuring things out. OTs as well, they do all of the above. They work on apraxia, like an apraxia is where you can't put the sleeve of your jacket in, or you're putting your underwear on your arm. You don't know how to dress yourself. You know that it's supposed to go on you, but you can't figure out how. Speech therapy, dysphagia. And a lot of times, and you guys, I don't know, we have a dysphagia eval and we have a cognitive eval for speech. If you ask them to do a dysphagia, they're not going to do cognition. You have to ask for both because they won't do it. And it's not that it's their fault, it's just this is what the order you put in. Aphasias, receptive, aphasia, you know, expressive issues, writing. Speech therapists do a great cognitive eval. Oh, so many of them do. We do not have neuropsych here, which is what we really need to have for a head injury. So our speech therapists are our neuropsychs. So don't think that a patient's cognition is fine, and you guys in peds are different than us. Like we're like, oh, they're fine. She's answering questions. She knows what year it is, whatever. Can she do money management? You know, can she add this quarter, this dime, and this penny? No. But we didn't ask her that. So we send her home, thinking she's fine, and she can't do that. So just think about that stuff. Rehab nursing. Rehab nursing is a special deal. I mean, they are 24/7 educating patients. They're not having them for 2 or 3 days and going. We've got them for 2 and 3 weeks, getting them ready. And so it's just, it's a different thing. Case management, of course, getting them home, all that, you guys know. But that's so important in education too, getting patients out. So here are the FEM scores for doctors and dummies. 7 is complete, independent, just like you or me. It's timely and safely. If they're not safe or they're really slow, then they're going to be a lower level. Our PTs use like Min-Assist, Mod-Assist kind of stuff, but this is sort of our score. But total, 76%. So like, you got to help them 76%. They're not doing much. And Min-Assist, 1 to 25% help by the helper. So a lot of head injuries will never get higher than a supervision level because of safety. They're not aware. They're impulsive. So that's kind of where you look at it, like, what kind of gains can I make? And I can't get above a 5. So if they're at a 5 already, if they're walking and dressing themselves and everything, but they're kind of goofy, I can't get them higher than a 5. Can they benefit from rehab? Yes. But they are not appropriate for, unfortunately, for acute inpatient rehab. That would be more like outpatient or like a higher level neurocognitive rehab, which doesn't take Medicare or Medicaid, only private insurance. That's a whole nother issue, anyway. So neuropsych testing, every head injury should have something, especially in pediatrics. Oh my goodness, because you've got a child. Like if it's a 78-year-old man, it's not so big of a deal, but this child, you really need to know where they are and where they're getting, and so you can figure out where they're going to be. So, and younger than 5 are the worst issues. Those don't recover, but like 5 to 15, they recover great. So even a mild head injury, like I said, at the very least, speech cog and follow up. Follow up with speech, not just send them home by. Mama they're okay. So these are the medicines to avoid. Haldol is a dopamine antagonist. And in a head injury, you have low dopamine anyway, so you don't want it. And so it's prolonged post-traumatic amnesia. Reglan is a dopamine blocker too, and I love Reglan for constipation. I'll use it for a couple of days on older patients here and there, but it's not good. The central alpha-1, like prazosin, is sedating. Clonidine is sedating. And we do use clonidine, I see it a lot for blood pressure issues and head injuries, but it's not the best. H2 blockers, like Benadryl and others, those can be sedating. So, and then anticholinergics too, which the dry mouth like I have right now, and I think that's it. Yeah, so these are the meds to avoid, all of those. So was that speed rant? Was that speed talk?
There you go.
That was pretty speed talk. Anybody have any questions or comments or?
You're going to convince the idiots down in Baton Rouge that are making us take this 3-hour course on how not to prescribe opiates, that Haldol is not a great drug?
I don't know. You talking about the board people?
I'm talking about the idiots that are telling you can't get a medical license until you've taken this 3-hour course.
For opiates?
Yeah, the drug abuse course.
Oh, I don't have to take it.
Sure you do.
Well, nobody's told me I did.
You want to have a medical license?
I guess.
You're going to have to take it.
I've missed it. I do chronic pain.
It's online, of course. Everything's online.
I guess I'm going to have to take it. But, opiate, there's a reason. Pain medicines are for pain. And when appropriately prescribed, they're appropriate. And there's a higher risk of abuse later in life, even when it's appropriately prescribed for pediatric or teenage patients. And those studies have been done. But, gosh, what are you going to say? Just suffer? I had an orthopedic surgeon who's would stop the pain meds on the patient with the knee replacement. I said, I can't wait until you're hurting because I'm going to stop your medicine. Yes, ma'am.
What's your go-to for adaptation normally? Like if it's not Haldol, I mostly see Haldol Ativan like that. And,
Yeah. Ativan for acute. Geodon IM is, great. The beta blocker takes a few days to get going on, but I don't mind Ativan because for short term, we're not going to use it long term, and they're not going to be agitated long term. If they're agitated long term, that's a whole nother issue. That's not agitation, that's a result of their brain injury, and it's restlessness and hyperactivity and stuff, and so that's, but like we had like a beta blocker on one guy, some old guy that was doing great on the beta blocker because his heart rate was 110. But the guy whose heart rate was 60, we'll put him on Geodon. So my favorites, like Geodon and Seroquel at night. If they're more agitated in the evening, like I'll try that one just because it lets them get their sleep cycle going and they don't have anything during the day, because Geodon might, but if we do Geodon too, we like it lower dose in the daytime and higher dose at night to do that same thing. So, I guess it's sort of patient specific and situation specific, but those are my favorite. Amantadine has been shown in studies too to decrease agitation, because if you're waking them up and they're more aware, then they won't be unaware and just fighting everything. So, and if you can, get them out of restraints. I mean, wouldn't you be agitated if somebody put you in restraints? So the posy bed isn't as fun for them because they can't go anywhere, but at least they can roll around and take their clothes off and whatever, but they're safe. And so I don't know how often y'all use those in peds, but we've been using them a bit more up here, usually in the head injuries that are hard to place.
I've never seen one use it.
Yeah, peds was my least favorite rotation. Dr. Bocchini looked at me and said, Lee, you're not enjoying this, are you? I said, no, sir, I'm not. And I have 4 children, which is sort of ironic. Anyway, done?
Thank you. Appreciate it.
Was it okay?